shock. He was resuscitated several times before. Blood pressure was on arrival about 60. So we put him on Impella. This was not enough. We put him on additionally on a balloon pump. And as you can see, he lost pulsatility for 3 days, and then he was able to recover. And actually, this is the patient. He's 4 years later, he's still alive and doing very well. So very often, I think in these unstable patients, you don't really have the choice. You have to treat the patient, and you have to achieve somehow flow in most possible branches you can. What is important, and I think this is really a crucial point, and I know financial issues are a big problem, but we know that mortality in the recently published culprit shock trial is still very high in shock patients with acute MI. And as you can also see, importantly, use of hemodynamic support is also very low. And I think this is related to each other. I think these patients die more because we don't use adequate hemodynamic support. And why is that? It's actually very clear. If you have a low cardiac output, then you have a low blood pressure, then you have vasoconstriction, you have tachycardia, you have low coronary perfusion, and then of course you have more ischemia, worsening myocardial dysfunction, and more cardiogenic shock. And we need something to reverse this process, and I think that's probably something we need. We need some form of a pump. Here I have put the Impella in the center, but it can be an ECMO. But I think patients who are in severe cardiogenic shock, in those patients we first need to treat the shock, and then we need to treat their vessels. This was a patient, 55 years old, with a non-STEMI. He arrived with a very low blood pressure, but then needed also catecholamines at the beginning, but then stabilized with some medical therapy. And if a patient has stabilized and he's fine for the moment, and he has a left main bifurcation lesion like here, I think in these patients, if they are stable, we don't need hemodynamic support. We need to treat this artery, in this case the left main, in a very smooth and slick way and as quick as possible. So in this patient, the LV ejection fraction was 40, his LVDP was 25, so I decided to keep it simple, don't put a pump in this patient, just stented, pre-dilated with a 3.5 NC balloon, put a 4.028 drug-eluting stent, left main to LAD, and the result was good post-stent implantation, and then I did pot and kissing, and the final result was good. So this was the easy patient who initially looked much worse, but then actually turned out to be quite a good patient who can be treated easily. I will show you now a different patient, probably one of the sickest patients I've ever been treating and who survived. This was an 82-year-old lady with an acute posterior MI, and this lady requested therapy. She said, "I don't want to die." And that's why she was transferred from another hospital to our hospital for the treatment of infarction. Her blood pressure on arrival was less than 80, and she was on massive inotropic support. But she could still think clearly and speak clearly, and she said, "I don't want to die, you have to treat me." This was the coronary angiogram of this lady. If you expect a big right, I can disappoint you. So how can I treat this patient? For that moment, I was shocked. I said, okay, well, let's see what we can do. And I think before I decide here on the strategy and think, how should I tackle the LAD, diagonal bifurcation, how should I tackle the trifurcation, first I have to stabilize this patient. And in this patient, I think it's really important, first treat the shock, then treat the artery. And of course, again, keep it simple. However, the anatomy here was so complex, you can't keep this very simple. And in my opinion, I would consider finishing the procedure at a later point in time. So in this patient, I said, okay, let me just first put an Impella in. After I put the Impella in, she stabilized quite rapidly. And then I opened the circumflex, because this was the culprit artery, and I stented the circumflex up to the left main. Then the patient was still not very stable, and back then, this was before the culprit shock trial, I said, okay, let me try to cross the LAD. So I crossed the LAD, it was a chronic total occlusion, but it crossed very easily, and then I was having the LAD diagonal bifurcation and the trifurcation in the left main. So then I decided to leave the diagonal alone, because I cannot do everything, and then basically stent, do a kind of mini crush with intermediate branch and LAD to left main. and then do the kissing, so both sides kissing, and this was the final result. Luckily, the patient survived, and this was her ejection fraction or LV function when she was discharged from the hospital. She had some moderate to severe MR, but the patient is doing well. I see her now regularly in outpatient clinics. She's doing very well. And I think in this case, I had no choice but to treat the cardiogenic shock, and then I had to somehow find a solution for this bifurcation and bifurcation. It was a mix of a complex and simple approach. And then I will show you the last case. This was an 83-year-old gentleman with a non-STEMI again. His blood pressure is 50, ejection fraction is about 40%. He has ongoing chest pain, and he has this LED. This is not a surgical candidate, of course. He's old, and he has a very complex lesion, extremely calcified LED. So here, I think I have to choose a strategy, and I know that I have to stent the left main. Again, I have to think of a smart strategy to do this. And in this patient, I decided to go for OP and NC and not use rotablator, and I decided to put a 4 French sheath in the left groin in case I need hemodynamic support, and put an impella. And then I had the anesthesiology team in the cath lab to support me with inotropes if needed. The patient then tolerated the procedure extremely well. We are a dedicated high-pressure center, so we used the OP and balloon at 45 atmospheres, 1.5, 2.5 millimeter, and then 3 millimeters. And then I put 4 times Sierra, and this was the final result of this patient. For the left main bifurcation, I went again with a provisional approach, and it became fine. The left main looked a bit hazy here, as you can see. So for that, to just prove that I have a good expansion of my stent, I did a final OCT, and this OCT basically showed that my stents were extremely well expanded, and that even the left main, which was highly calcified, I had a very nice expansion. Of course, the stents cannot inflate in a circular fashion, but the patient survived. Let me just, for the sake of time, quickly switch to the... So this is then the left main portion. So I was quite happy with this result, and the patient is still doing okay. So if I may summarize, I think in patients with hemodynamic instability, we need to treat the shock first and then treat the patient. And I think in these patients, of course, I'm in the comfortable zone of using an impella for every patient I want, because I don't have any financial restrictions in Switzerland, but I'm aware that I work in a very rich country. However, I think if you can use at least IABP, it's still good for the patient because he will benefit. And I think the bifurcation strategy should be as simple as possible. Especially if no hemodynamic support is available, then you should try to get out of that patient as soon as possible and leave him with good flow, and consider postponing the procedure if necessary. Thank you very much for your attention.